All right, welcome everyone. I know we're all still getting settled here. So good to see all of you tonight. This is our first Timothy A. Johnson Medical Scholar Seminar of the year. So we're really happy to have such a great turnout, both from our students and from several of our faculty members. I'm just going to say a few words about the seminar series itself. So Timothy Johnson was actually the first Associate Dean of Research at our School of Medicine. He was a biomedical engineer who studied sudden cardiac death. And when he came here, he was very passionate about the idea of blending researchers and their work with individuals at the front lines of patient care. And so he very much was passionate about this idea of bringing together our researchers. In this case, we've got many of our translational biology, medicine, and health students here with our medical students to share in this idea of research that is really at the intersection of patient care and discovery. So you'll see in this series that we have, our speakers are always physicians that are actively engaged in clinical care. They're nationally recognized for scholarly activity. And this seminar series is a key part of the medical school curriculum that is focused on the 3 identities that you see up here. What we do as we think about our curriculum across all 4 years of our medical school is think about developing a patient-centered physician that integrates the identities of a system citizen, which is someone who's thinking about the systems level factors that impact patient care. So our first speaker is going to be an excellent example of that. Someone who's a lifelong master adaptive learner who is always thinking, what do I need to know? What are the gaps in knowledge that I have? And then a scientist physician, somebody who's thinking about how you can advance actually the fundamentals of the field. And so although one might think that a series such as this really falls primarily into the scientist physician category, what we find is that so many of our speakers encompass all of these identities, mainly because they ask really good questions. So we feel like this series is so important to both our graduate students, our medical students, and our faculty to see how you can blend all of these attributes into something that creates better patient care and new knowledge. So with that, I'm going to go ahead and hand it over to Dr. John Epling, who is the Vice Chair of Research in Family and Community Medicine. And he's going to tell us a little bit about tonight's speaker.
Thank you. Thanks, Dr. Ganti. I have the distinct honor of presenting Dr. Alex Krist. He is a professor of family medicine at the Virginia Commonwealth University. He also has a clinical practice and is on the residency faculty at the Fairfax Family Medicine Residency Program. He's Director of Research in the Department of Family Medicine at VCU and is the Associate Director of the Wright Regional Clinical Translational Science Center, VCU's CTSA in Richmond. At a small liberal arts university just north of here, he received a chemistry degree and a medical degree, the University of Virginia, I think is what they call it. Yeah, so had his residency, that's a little dig for those of us that are Hokies. Residency at Fairfax Hospital. He did a faculty and research development fellowship at VCU with an M.P.H at Johns Hopkins. And he's been on the Fairfax Hospital Family Medicine residency and working in VCU since then, and has now worked all the way up to professor. I would relate all the awards, publications, and presentations that Dr. Krist has gotten, but then we would be here till quite late, and I want to hear him say a lot of stuff. So I'm going to just suffice it to say he has multiple honors and awards throughout his training and career. The CV is truly awesome. He's had multiple statewide and federal advisory roles, mainly centered around prevention and the advocacy for primary care. We've mostly got to know each other during our tenures on the U.S. Preventive Services Task Force. So he preceded me by 1 or 2 years and took on the vice chair and then the chair role throughout my tenure on the task force. And we really got to know each other then. And he made that task, in addition to the honor and the hard work it was, he made it actually very fun. He is a member of the National Academy of Medicine. He wrote the report on whole health for veterans that you may have seen from the NAM, and also was on the committee for the report to the about high quality primary care, both very influential reports about how we structure primary care in the United States. He does lots of important work, as I said, for the state of primary care in Virginia and the US. He's dedicated to showing and advocating for the value of primary care. We used to sort of joke on the task force that he sort of was the media punching bag. He often took on the most controversial topics and did a lot of media for those. He was up defending our prostate cancer recommendation and several other controversial recommendations, and always did a fantastic role. It was really a model for the rest of us on the task force. His chair tenure on the task force was sort of bittersweet. It was right during the depths of COVID. The task force operates as a pretty collegial organization. We like to get together and talk about our recommendations and see each other, and all that went virtual. And so it was a tough time to be the leader of a group like that. In addition to COVID, we had lots of intense discussions about the role of race in recommendations, the role of race in the organization of the task force. And Alex led those extremely well. And that was a very, very challenging, but I think a very productive time for the task force. I am honored to be his friend and his colleague, and I present Dr. Alex Krist.
Wow. That's very kind of John, and I appreciate all those nice statements, and could say a lot of nice things about John as well here. I've enjoyed working with him over all of the years, and I've enjoyed working with Carillion over the years. The talk I'm going to talk about today involves a lot of research that's actually being done here as well. So this is not just a VCU type of a thing. And I'm going to try to talk about this idea about implementing evidence into practice and show you 3 studies in particular around this. And I'm hoping to accomplish 3 things. I want to talk about practice-based research networks. So we started talking about it a little bit with the students over lunch today. And then I'm going to try and share these findings of 3 ACORN studies. So ACORN's our primary care practice-based research network in Virginia, and Carillion practices are part of ACORN. I think they're a very important part and have helped with a lot of our studies recently. So the work I'm talking about today is work that you all have been doing, and I get to stand up here and look like I'm taking credit for it, but a lot of other people did it. And I'm going to talk a little bit about a vision on health equity research. So the Agency for Healthcare Research and Quality has kind of put this definition together about practice-based research networks. They have a website. They list all the PBRNs. There's about 120. There's probably 10 to 20 really active ones throughout the country. Colorado, Oregon, Washington, and Virginia is one of them. And Virginia's is non-denominational, involves all the health systems. We have all kinds of practices involved. And they're often around primary care. They don't have to be. I know there's some nursing networks, there's some dental networks. I've even heard about an ENT group that wants a network, but they originated in primary care. And it really is about practices and groups coming together, working to answer community-based healthcare questions and translate research findings into practice. And they're meant to engage clinicians and communities and to think about improving health and how we're delivering health. There's a couple of foundational articles about this. I put this here if you're interested and you want to go read about it, and they can talk about, well, how do they work and what's the history of it? They originated really probably back in the 70s with the original network called Aspen, but then in 1996, ARC started funding them, and Virginia's network has been around since 96. So that's our network, and when I say we're non-denominational, well, we have 524 practices in the network. Not all the practices know they're in ACORN. So if you ever do a study with you, we say you're part of us, right? So there's not any big agreement or data sharing or other things. It's just that you want to work together to try and improve health for the communities and the people you serve. And we have everything from like single doc direct primary care offices to large multi-specialty health system practices. And you can see they're all over the state. So that's part of our goal here. So why do we need PBRNs? This is the ecology of care by Larry Green, right? So if you look at 1,000 people in the community at any one point in time, about 800 people are going to have some symptoms from some health issue. About 327 will seek care. And you can see as you go down, like maybe 200 people will be seen in a primary care office. We know that in any year, only about 40% of Virginians go to a primary care office. And then you go all the way down to less than 1 person out of 1,000 is seen in an academic health center. That's where all the research occurs. 0.1% of the population that it represents. So the idea is we need to get research out into the people that are going to benefit from it. So how do we move this and bend this curve and get this out into the broader community here? Here's another reason we need PBRNs. This is a study by Beth McGlynn in 2003. And 2003 sounds like a long time ago, but the data is no different in 2024, and it was the same in 1970 as well. Americans over there on the right only receive half of the care that we know they should get. It doesn't matter whether it's preventive care, chronic care, or acute care. We're not doing a good job at making sure people get what we know will help their health. And then if you look on the left, you can see we're bad across a lot of services. We're a little better at immunizations. Maybe that number's worse now with COVID and COVID vaccines, but we're really bad at counseling and education and health behavior change, and some of these things that really affect people's lives more than anything. So some characteristics of practice-based research networks is they're about collaborative approaches. It's engaging with stakeholders. It's working with frontline folks. What I heard you say is important about this initiative and the work that you all are doing. It's a real world focus. Like, this is the problem we have, and how do we go about solving it? And it's supposed to focus, it often, in our case, focuses on primary care, but it could focus on other specialty issues. We've struggled in ACORN of saying, well, what's our mission? We've had multiple mission statements over the past 20 some years. But really, we kind of settle in on, we do research that matters to primary care. So that means it matters because it's stuff they're doing. It addresses the people they're caring for. And our goal is to do those 5 rights, to make sure the right care at the right time is easy to do and it's given to the right people. We use a lot of CBPR techniques. And we try to have all of our studies not just measure, are we improving health for patients and communities, but are we also improving the process of delivering care? Like, does the care team feel better? Is it easier? Are they happier? Do they feel more confident and competent in what they're doing? And then we try to make all this stuff statewide. So it's not meant to be at VCU or up in our Fairfax practice, although a lot of our studies will occur in different regions and different settings, depending on what people are interested in. Data is another big thing, right? Data sharing and data silos is a big problem that we have. So we try in ACORN to share data. We don't have a central data system, though, because our practices have 84 different instances of electronic health records. That would be impossible to bring all that together. So we try to bring it together, though, more around studies. And it's much more about being an expert at accessing data and how do you use it and how do you navigate things, which a lot of it is about policy and IRB and other things, more than it is the technical issues. I jumped ahead on the data. This was supposed to be about spanning. So the practice-based research network is supposed to span a lot of different disciplines. So we work with policymaker, informatics, leadership, and health systems. This was the data slide. I jumped ahead and talked about that too early. So these are some of the studies we're doing right now in ACORN. I'm going to talk about 3 in particular. And the first one was something that Carillion was very super involved with. But we're getting ready to launch the Virginia Cancer Screening Research Network. So we're one of 8 national hubs to study new novel ways of how do we screen for cancer. We have a PCORI study where we're doing a comparative effectiveness trial on how do you treat sinus infections. So did you know there's actually no evidence on antibiotics or nasal steroids or anything for sinus infections? This whole thing about wait 10 days and double sickening, it's all made up. So we have a PCORI pragmatic trial. We're randomizing people to get nasal saline versus nasal steroids versus antibiotics versus both steroids and antibiotics. And we're going to see if it works. And we're going to get some evidence on like the most common primary care thing that we do every day and we don't have evidence for. We're developing a toolkit for the Virginia Opioid Abatement Authority. Virginia gets $8 billion to give to cities and counties to try and develop interventions on how to reduce opioid overdose deaths. If you haven't watched John Oliver's episode on it, he makes fun of all the states getting it and how they're just putting it into police and other things, and it's not evidence-based on what they're doing. Virginia's actually trying to look at evidence and what are specific problems in specific communities and what should they be addressing. And we have this sustained study where we're trying to help practices screen and counsel for unhealthy drug use. We're trying to evaluate the Virginia Mental Health Assistance Program. We're trying to assess primary care capacity in Virginia. We're trying to look at the effect of ownership of primary care on team-based care and on how practice of primary care approaches delivery. And we're looking at the interprofessional teams in primary care. And then we have this VA Ahead health equity dashboard that I'm going to talk a little bit about. So at the very beginning, I said PBRNs do a lot of quality improvement research, but you can see we do a lot more than that. So we've got comparative effectiveness trials and screening trials and other things. So a PBRN really can do a lot more with this broad collaboration. So let me talk about the unhealthy alcohol use study. And a third of this was done here in Carilion, and John and Michelle Rockwell were really key in this study. And I want to show you some of the impact that a PBRN can have on community and community health. So unhealthy alcohol use is a whole spectrum of disorders. So this is everything from excessive drinking to alcohol use disorder. It's the 8th leading cause of death, 4th leading cause of decreased quality of life, and it's the 3rd leading cause of preventable deaths in the US. 2/3 of the deaths are from chronic conditions, liver disease, heart disease, cancers. 1/3 are from acute things like motor vehicle accidents or suicides. And we spend $250 billion a year from like lost work and law enforcement and accidents and things. So this is very costly and it interferes with the length and the quality of life. And yet we're really bad at addressing this. And it's recommended, I'll show you in a second, to screen and counsel for this. But when you think about alcohol and what's a safe amount to drink, the bad news from the World Health Organization now is probably any amount of alcohol is not good for you. So that adage, 1 or 2 drinks might help you. There's some data that any amount might not be good for you. But we define excessive drinking as women more than 7 in a week, men more than 15 in a week, and having binge episodes of more than 5 on an occasion for women, or 4 for women and 5 for men. Now, alcohol use disorder is this other part of the spectrum, which is more that maladaptive pattern of drinking where it starts to affect your quality of life. It's affecting your work, your social interactions, and your health. Most of the health problems from unhealthy alcohol use and most of the people with unhealthy alcohol use are more in the excessive drinking. And it's 1 out of 5 people. That includes 1 out of 5 of us, 1 out of 5 doctors. It's a very normal thing, and it's something that we can do to do interventions to help people. So this is the task force recommendation that you screen and counsel all adults over the age of 18 about unhealthy alcohol use and provide counseling to help them with this. The screening instrument is either this SAS-Q, where you ask about the single question on binge drinking, or you ask this audit C, these 3 questions that get at the frequency, the average amount, and the binge drinking. Now, I'll tell you, most primary care clinicians don't use the validated instruments, and that's what we found in the study, and I'll show you that. And so we have recordings and other things about doctors, and the most common thing is you don't drink too much, right? And you can guess what the answer to that question is going to be versus this type of a question. So it's really important to use the validated instrument. And then when you look at the data that the task force was looking at, there were 65 trials that did all these different designs in different settings, had different components, different duration, intensity, different mean contact time, but they showed that brief counseling in primary care reduced the amount that people drink. So it's reduced the daily amount and the number of days that they drink and the number of times that they have binge drinking. And that this is something that's more in line with like counseling patients on not smoking. So if you think about the behavioral counseling that can occur in primary care, something like counseling to help people lose weight, that takes an average of about 60 hours of contact time, or I'm sorry, 26 hours of face-to-face contact time over a 6-month time period to help people change diet, exercise, and lose weight. Smoking cessation can be done in 2 minutes, so can reducing unhealthy alcohol use, and yet it's not done in primary care a lot. And those outcomes of those trials were that it reduced the amount people would drink, and that could reduce progression to alcohol use disorder and developing lifelong problems from alcohol. So our study was, we were charged with trying to provide practice facilitation for 125 primary care practices, and we launched our study February of 2020. Very bad time to launch a study in primary care practices. So we recruited a couple practices, we put it on pause until September of 2020, and then we started recruiting again. But it was a very hard slog. And we randomized practices to get this practice facilitation. And I'll talk in a second about what that is. Up front or 6 months later, they would get practice facilitation. So the delayed practices served as a control, and up front were our intervention practices. So it was a practice level randomized control trial. And we assessed, did they increase screening, counseling, medications, intensive therapy at baseline, 3 months and 6 months. Practice facilitation meant that we went in and we found champions in the practice and we got them together and we helped them think through what's their workflow. What do you do? How do you approach this? What instruments do you use? What's in the EMR? How do you approach this? And they developed a plan. And then we provided a lot of educational material for everyone in the practice. And they could do 1 session or 4 sessions, whatever they wanted to do and whatever their clinicians wanted to try and develop their approach in their practice and get all of their staff on board. A lot of them just did 1 session, so it was a lower hands-on intervention, but some were more intensive in this. And it was really, we had these educational content in 4 training sessions. We have a toolkit that we put together so they could all do it asynchronously if they preferred. So here's our recruitment. And, you know, after the fact, we wrote it up really fancy-like so that we did these waves of recruitment, but really this was us trying to survive and get to 125 practices. But our first wave of recruitment was through our residency programs. You know, we train clinicians, they go out and they practice in the communities near us, and we were going to use all those connections, and we thought we could get 125 practices. So that's the first wave up there, and you can see the communities they cared for. Well, you know, that was September of 2020. We got a number of practices, but not enough. So then we started recruiting through health systems, and you can see it shifted more. There's more recruitment around bubbles where a bunch of big health systems in Virginia are. And then we did a targeted approach. We went back and we looked at our first 2 waves and we said, okay, where are we recruiting people and where are we missing people? And we added in and targeted the primary care practices that cared for communities that weren't included. And then what that resulted in is we got 76, not 125, but Virginia got more practices than any other state agency working on this. The others got 22 to 44. So we did pretty good. And in the end, the people we recruited looked exactly like Virginia. So we had a very good distribution in terms of race, education, income, ethnicity, all of these factors. So it was a very inclusive type of a recruitment approach, and that's something that we try to do. Now here's our baseline data. I was telling you that primary care is not very good at screening. So what you see in that first red box is that about 70% of the time, primary care clinicians are documenting something about alcohol. But they weren't using the validated instrument. We found that they only used Audit C about 10% of the 60% of the time that they did screening, and SAS-Q was even less. And then they only found about 9% of people with unhealthy alcohol use. I told you at the beginning, it's about 20% of people, so that's too low. And then they only counseled 15% of people who had identified unhealthy alcohol use. So there's a lot of room for improvement, and we knew that that would be the case. Here's the results of our study. So if we compare any documentation of alcohol use, there was still high levels of any documentation, but not with the screening instrument. If you look at the second row using Audit C or SAS-Q, the intervention practices increased from 2% of all of their patients to 35%. That's a pretty massive increase. I haven't had many studies where we have a 30+ increase, and that's an adjusted value. The raw value is more like 45% increase. We didn't necessarily increase identification of unhealthy alcohol use as much as I would have liked. And I think that's because we were asking patients the question. And you do better if you actually can automate it and send it to people before the visit, because then they're more likely to answer the questions honestly. And we increased our brief office counseling from 20% of patients to 62% of patients with unhealthy alcohol use. Now, the control practices interestingly had a high rate to start with at 45%. But remember, this was a subset of all of the patients. So this represented the people who had identified unhealthy alcohol use. So there was some variation there, but they didn't see the same increases we saw in intervention practices. Now, to get this data, to put this into context, we did 12,000 chart reviews and we mailed 12,000 patient surveys. And the surveys were mailed 3 times until they completed it. So that's a lot of surveys and chart reviews that everyone worked together to do here. But what this meant is in any year, we increased screening by 114,000 people in Virginia by training those 76 practices on how to do this. That's 1.2% of all Virginians are going to get screened now. if we continue this in this process that wouldn't have been screened otherwise. And we increased counseling by 8,235 people a year. Those are big population changes beyond like a little QI initiative and beyond what happens in a lot of traditional randomized controlled trials. This was a sub-analysis that Michelle did, which was really cool. She looked at people with multiple chronic conditions. And if you have mental health chronic conditions, you are more likely to have unhealthy alcohol use, and you are less likely to have doctors ask you about your alcohol use. So this gives us an idea of the type of people that we might need to think about working on more. And then Ben Wiebel, who's one of our research coordinators, wrote his very first paper ever when we had to switch to virtual counseling. He calculated he was going to drive to every practice. That would have been crazy, actually, thinking about it. But he calculated how many miles he didn't drive, and he figured out he'd save 15 acres of trees by not having driven those 32,000 miles. So that's actually important if we think of health and our outcomes. Now, we have a lot of things we need to do to improve what we did here. This was a good start, but there's a lot more that we can do, particularly improving kind of the counseling aspect and the identification of unhealthy alcohol use. But this is starting to get this change, and we're planning to track our practices and see, do they sustain this? You know, can we see in the all-payer claims data in Virginia that they continue to identify people and provide counseling in the claims data? And our hope is that we'll see this. I'm going to move to another study, and this was a clinician-level randomized control trial that we did about trying to address root causes of poor health. So for people with multiple chronic conditions. And if you think about health and healthcare, like here's the sad news for the medical students, and don't get discouraged by this, but like you only have 10% influence on people's health with all the stuff you do, right? Like 40% of health is due to social and economic factors. 30% is due to people's behaviors. Now that 10% of what we do is important, but the real question starts to become, okay, how can we start bending the needle and having a greater impact by trying to deal with these other things rather than just ordering tests and prescribing medicines and doing more conventional biomedical therapy? And there's been national calls for screening for social needs routinely. You see this from the World Health Organization, National Academy of Medicine, the primary care collaboratives, payers, CMS, others are all saying we need to be screening for social needs. And I don't know if you have this, but up in Inova where I am, we have one of our key performance indicators is how often do you do the social wheel on the storyboard and ask all of the social needs? And we've done studies back in 2012. We did a study in our primary care practices where we screened for social needs before a doctor saw a patient. And then we told the doctor the patient's social needs. And then after the visit, we asked the doctor to reflect on what knowing that did for them with the visit. And the responses were interesting. The first thing is they were very frustrated. They're like, don't tell me this person is poor. I can't do anything about that. And they were a little bit angry about that. But the fascinating thing is they went on to say that for 50% of encounters, they did something different. They talked to people differently. They prescribed a different medicine. One doctor said, I thought they were just non-adherent and not listening to me. And then I realized that what I was asking them to do, they couldn't do. So it changed the way they thought about their patients. So we need to think about, well, what is the role of knowing about social needs and how do we put this into practice? And we don't know this, even though we have national calls to screen for social needs. So this is our idea about looking at people with multiple chronic conditions. So over the age of 65, 4 out of 5 people have multiple chronic conditions. This is a big cause of multimorbidity and loss of life in the US. And how can we move past conventional medical care and address health behaviors, mental health, and social needs? So this is a clinician randomized controlled trial. We ended up having 81 clinicians and 30 practices participate, and they were randomized to continue what they're normally doing or get what we called enhanced care planning. And our idea was, let's try and create something that might be feasible to do in primary care. We're not asking the primary care doctor to fix all the social needs in the world, but let's put a plan together, and I'll show you what that is in a second. And all of their patients with multiple chronic conditions were invited to participate. And if they were control clinician, they did the normal thing. And if they were intervention, they did enhanced care planning. And the enhanced care planning was 4 things. We had them use an online tool, My Own Health Report. It asked about 23 health, behavior, mental health, and social needs, and then showed them where they scored in an area that they might want to make some improvements. and guided them through picking one or two different domains and creating a care plan. And we showed them evidence-based strategies to address it, and then they could type things in. And then we connected them with a patient navigator who went over this plan with them. So it was like an automated aspect that they do on their own and a supported activity with the patient navigator to figure out what they want to do. We linked them with a community health worker, and we tried to connect them to all the community programs that are out there to help people address these different needs. What I'm going to show you here, we have preliminary data right now. We're year 5 of 5 for this study, so I can't tell you the overall results. I can tell you that the intervention group looks like we're improving that people's social needs, mental health, and unhealthy behaviors are getting better. So the preliminary data on that looks like we've changed that. But whether that leads to improved control of multiple chronic conditions, I don't know the answer to that yet. But part of me doesn't care if your A1C is better if now you have a house and you didn't have it before. So I might be rethinking what the ideal outcomes of this study are compared to what we wrote versus what we're finding. But this was a fascinating thing. 100% of people in the study, of all of the clinicians, patients with multiple chronic conditions, had at least one unhealthy behavior. And 66% had mental health needs and 50% had social needs. This included Richmond practices and Fairfax, Northern Virginia practices, which are some of the wealthiest counties in the country. And there's still a lot of social needs and mental health and unhealthy behaviors. The thing that discouraged me, though, was that 90% of patients with an unhealthy behavior picked that as their care plan. Only 23% with a mental health need picked that, and only 12% with a social need picked that. And we actually, partway through the study, worked with our navigators and said, look, get more of these people to do social care planning and mental health planning. And if they do a health behavior, maybe prompt them and ask them to add in another one as well. So I think we really need some cultural change about, these are things that we need to be addressing in our healthcare system. And how do we do it? Because we've done interviews with patients, and a lot of them just said things like, well, I didn't know my doctor or the health system or this practice could help me with this. Which kind of surprised me for mental health, but didn't surprise me for social needs. Now I want to talk about moving a little further out into the community. And this is some work that we call bright spotting and community asset mapping. And this is our health equity dashboard that we just got a grant to create. And this is through our CTSA. And the idea here is that we really need to be co-creating the data and the information with communities and the people that we serve about what's important to you. So that's part of the whole health initiative where, the NUCA health system goes out in the community and says, well, what matters to you? What do we need to be delivering? How do we need to help you? So we're trying to create data and a dashboard around 15 health equity topics that we co-create with communities that we work with, and then find the different inequities and then identify the socio-ecological factors that lead to different outcomes in communities and track all of these over time. Create basically community scorecards where you can think about interventions and how you want to approach things. And the CTSA grants are supposed to be about building infrastructure to support research, clinical care, or policy. So our outcomes on this study are going to be through this tool and engaging communities with this tool. Can we get more people to do research and help them with their research? And can we inform clinical operations, and can we change policies? And this is the pathway we use. So the first is you identify the problem. And so I'll give you an example of opioid overdose deaths. And then when you identify that problem, work with the community and look at all the factors that lead to bad outcomes. So part of that can be the data and what does the evidence say, but part of that's working with the community and say, what's your lived experience and what says what's important to you around that. And then from that, we create this multivariate model with all this data. So we put together all these socio-ecological factors and the outcome of opioid overdose deaths, create a multivariate model that will predict the death rate. Then we apply that model to each individual census tract. And we look at, do they do better or do they do worse than expected? And the communities that do better, we're calling bright spots. And the communities that do worse, we're struggling on the name, but it's sort of a cold spot. You could debate what the name is. But you compare the different characteristics of the community and how do they look different and what might be the resources in communities that do better than predicted or the approaches and strategies. And then how can we take those resources and approaches and strategies and disseminate them more broadly to other communities? That's sort of the general idea behind this. And it's supposed to be a strengths-based approach. So we're focusing more on the bright spots and talking about you're doing really well as opposed to here are the places that are doing bad. And in healthcare, we tend to focus on people and communities that are doing bad, but there's a lot to learn from the strengths-based approach. And then we're also trying to blend data with lived experience. So one thing is you take this data, which will just give you associations, but you start engaging and working with the communities and lived experience, and you can start figuring out like what might be more than just an association. And then if we longitudinally track this over time, can we actually bend the curve on these different health inequities and try and make things better? And this is kind of like a 3x3 table that you can imagine. So all the way on the left is like your actual outcomes. Like we know every census tract that has the highest number of opioid overdose deaths to the lowest, right? That's sort of the y-axis there. And then the x-axis is the predicted. So we know the communities that did much worse than predicted and much better than predicted. So you can be in a community that has a high number of deaths, but you're doing better than predicted. And why is that? What does that mean? And vice versa, you could be all the way on the other section in a community that has a low number of deaths, but you're really doing a lot worse than you should be because you're a good socio-ecological community and you should have better outcomes. What's going on there? So this is the data tool, the raw database that we have. This is on the web right now. It's publicly accessible. And we use a lot of different data sources to generate these different community level measures. And you can draw up data by census tract, by ZICTA, by county level, and eventually congressional districts, because we want to use it for policy as well as clinical care. And then what we really want to be able to do is to be able to say, okay, Carillion, where's your 70% service area? And be able to let you take either your practice or your health system and show you what are the census tracts that you serve, your practice and your community, so you can understand them and start thinking about their issues. This is how we get at some of the measures. So we'll use like the state mortality data. That's where we get at like opioid overdose deaths. And we use the Virginia All-Payer Claims Database. And so from that, you can actually calculate a lot of different variables that you wouldn't think about normally with claims data. Things like outcomes like emergency room visits, hospitalizations. Are you doing enough connections and are people getting the type of care that they need? And then we have a whole bunch of other data sources that are publicly available that we try to integrate around BRFIS and CDC and the American Communities Survey around the characteristics of communities. So these are examples of different measures that we're trying to create for every single census tract. Now, the actual health equity dashboard is going to look different than this. This is kind of clunky, and this is like an ArcGIS web tool that we can't change a whole lot. But what we're going to end up doing with our health equity dashboard is trying to have these 15 different topics, and to be a little bit more clear, it'll be organized more around that socio-ecological variable of the outcome and the bright spot outcome, and then the different variables in there. So communities and health systems and practices and policymakers can clearly look at what are some of the issues there. So let me talk about opioids and what we've done with it so far, because this is where we're furthest along on this model. So opioid deaths are going up. A lot of it is fentanyl. It's higher now in urban communities and among Black people. So that's a change in Virginia. It used to be rural areas and more white people. So it is moving and it is changing the nature of the opioid epidemic. And when we work with our different community partners, these were the different variables that we thought would be important to put in our models. So there are things around the population and characteristics of community, some aspects of healthcare delivery. And then we looked at a bunch of different outcomes, but the ultimate one was opioid overdose deaths per 1,000 people in the community. And this is what we found overall with the model. So first of all, mental health was a big predictor of deaths. So higher rates of mental health disease in communities leads to more opioid overdose deaths. Now, when we go to the bright spot, what's really interesting is the bright spot communities actually diagnose more mental health conditions. So they're recognizing it and addressing it. But overall, mental health is a driver for bad outcomes. And the communities that have lower rates of diagnosis, we don't think that that represents lower rates of mental health disease. We think that's communities missing that. Disability, divorce, urban communities, communities that have higher proportions of Black people, all of those communities in Virginia have worse outcomes. Here are our bright spots. Okay, Roanoke's not looking so bad. You're not lit up either one way or the other, which is good, but there's some places around here. Now, this is not the size, the geographic area. The bigger size of it is how bright they are or how cold they are. And an interesting thing is there on the Eastern Shore, there's a lot of bright spots there. And I'll talk about that in a second because we found some interesting outcomes. But when we started looking at the bright spot and cold spot communities, the bright spot communities had much higher rates of medication prescribing for opioid use disorder. They had more primary care. So if you don't have enough primary care, you have more deaths. They had a lower population density. And then the local collaboration and innovation. That's what was going on in the Eastern Shore. So here's the clustering of, on the left-hand side is the number of opioid medication prescriptions, and then the axis is the number of primary care visits. You see pretty strong correlations here where all of your cold spots are clustering with low numbers of primary care visits, low numbers of medications for opioid use. And you can start looking at, well, how does my community, how does the group that I serve compare to other communities? And what might that mean about what we should be doing and trying to change here? And if you look at the bright spot communities, you see the bright spot communities have more primary care visits, they have more mental health diagnoses, they have more opioid use disorder diagnoses as well. They're recognizing the condition and not missing it, and they have more visits for this. So it was a very, very consistent finding. And the other thing that's fascinating about the bright spots is the bright spots, the blue dots, didn't change year after year for 5 years. The cold spots moved all around. So not surprising, it's probably a good thing that the cold spots moved around. There's a small number of deaths in each community, so that's very highly variable. But the consistency of the bright spot really suggests over 5 years that there's something more than just associations here with this data. This was the population density from the bright and the cold spots. Now, this is a non-modifiable factor, so you're not going to go in and say, well, we're going to make this community less dense of people, but it can give you information about, well, where should we be focusing our energy and our resources and our efforts? So there's different ways to use this data on a community level. And this is what I was mentioning about the Eastern Shore. So we didn't know this, but through all this data, we're like, well, what's going on in this area? So this is our community engagement. And we went out there and we learned that they put together this overdose fatality review team. So anytime a person died, they brought together all of those sectors and they talked about what happened to this person, why did we fail them, what do we need to do different? And they became a bright spot. And they're kind of surrounded by cold spots too. So it's an area where you would predict based on their socioecological characteristics, they would have much worse outcomes than they do. And yet they did this thing that no one knew about outside of their community that really bent the curve on their population health. And so how do you diffuse that and get that out into other practices in other communities for similar outcomes? So with this grant, we're trying to advance this to 15 different topics. We're going to be looking at everything from primary care access to mental health to climate change and its effect on health. We're thinking about healthy aging in place, school readiness, gun violence. These are all the topics that our community partners have said that they care about right now. We're going to try to longitudinally track this and create scorecards that researchers and care teams and policymakers can use to influence what they're doing so that we can really have a coordinated effort in Virginia to make some changes and some differences. And we're going to try to see if people will use this and if this is going to work and help improve public health. So you can see here that I want to kind of conclude with going back to this ecology of medical care and trying to get research out to be very generalizable outside of our ivory castles in the academic centers. This is not an easy task. So this takes a lot of effort, takes a lot of collaboration. But on a positive level, there's lots of people, lots of different partners and stakeholders that are really interested in trying to do this. PBRNs are one laboratory that can effectively help make this change. And working with communities, there's just so much interest and excitement around this, going out directly into the community to make these different changes. And so for the medical students, when you get done and go out into practice, a lot of people don't want to do research, but getting involved with a PBRN, well, that's a way you can kind of get involved on a light level with doing research. It doesn't have to be very intensive work that you're doing. You don't have to write the big grants or the papers and have the publisher parish prospect, but you also don't have to be afraid of those things. And this is a way you can get involved. So that's probably a good place for me to stop. John told me I had too many slides, but I made it in under an hour, so.
Thank you so much, Dr. Krist. We will open the floor for questions.
I just wanted to say thank you for sharing with us. And I had a question about one of the first slides you showed, which was like the average American gets about 50% of the healthcare that they need. Is that like on a bell curve? So like 50% of the or like a significant portion of the population is getting like 50%, and then you've got a few individuals who are getting 100%, and a few individuals who are getting like 0%? Or do we have statistics on that?
There are some statistics on that. I don't know how great they are, but the number about 50%, if you add up all of the care that everyone needs, we're at about 50% across everyone. So I would expect that it's at a bell curve. We did another study where we created a patient portal. There was something called My Preventive Care, and we were trying to help them be up to date on 23 U.S. Preventive Services Task Force recommended preventive services. And we had, in our first analysis, we had 20,000 patients use it. And I think we had like 0.3% of people were up to date on everything. So like almost no one's up to date on everything.
Okay, thank you again.
Hi, I was wondering, since I'm a graduate student and I'm part of the research side of things, recently especially, there's been such a huge focus on statistical significance. And if you don't have that p-value under 0.05, your data shouldn't even be looked at. But with a study such as this, so much of the actual impact comes from the qualitative data. So how do you balance portraying the qualitative data and really getting that message out while still dealing with the red tape of if it's not significant, it's not worth looking at?
Well, I'd push back on the if it's not significant, it's not worth looking at, actually. And you know, if it's not significant, the big question is why and what's next, right? And we do have a publication bias where positive things get published and negative things don't, but there's a ton to learn with that. I think almost all of our studies are mixed methods. So we always include a qualitative component, and the qualitative says something that you can't get to that the quantitative doesn't say. So you can have statistical significance, but not like clinical significance or meaningful significance. So you know, that qualitative can help you with that. And the qualitative also helps you with understanding, well, why was it not significant? We've had a ton of studies that we do that aren't significant. And by going and trying to look at it and understand why, that's the next grant, that's the next study, that's the next iteration. So the failings is important with that. To your point, though, also, it's a little bit harder to get qualitative stuff published, right? Because people do look at this and they do push back on it. And you're not as likely to get something in JAMA that's a qualitative study. Although that unhealthy alcohol study, we got into JAMA Health Forum and we put a big qualitative table in there. I was kind of surprised they let us sneak that in. So it is possible. But I think with the qualitative, the other thing too is to make sure you're using good systematic methods. So, you know, that you're getting saturation, that you're having enough people, that it's representative, that the people that you're doing, that you have a non-biased objective assessment process for thematic coding and other things. So using a lot of those different research techniques can give that equivalent of statistical significance to your qualitative work as well.
We have a question from somebody online. Dr. Nick Ryder said, terrific work and talk, very impactful. And his question is, what strategies do you use to effectively engage with your community partners by longitudinal dialogue for identifying relevant issues?
Yeah, that's a great question. And, you know, I think I use my family medicine principles with research, right? So I just said our practice-based research network has been around since 1996. So, and I jokingly said that not all of our practices know they're in ACORN. I also didn't jokingly said that once you're in ACORN, you don't leave. So we like to maintain those longitudinal relationships. So that's a really important thing right there. The other thing is trust is very important. So we spend a lot of time going to the communities that we're working with, So for example, we have a community advisory board and group that we're working with of public housing residents on the in the Virginia Beach area and Richmond area as well. So we spend a lot of time in their community working with folks to try and understand things. There's some research methods where you can get at different questions. So one of our investigators has developed a methodology called the SEED method, where you kind of go through and you work through information together. Around that equity dashboard, some of what we're going to be doing is we have a lot of these different diverse and inclusive community groups that we've been working with, and we're going to try to go in multiple times iteratively with data and without data, kind of talk about what's important to them. And a lot of it is just listening, and then supplementing some of the data to try and help frame questions and direct that in the right direction. So I'm not sure if I completely answered Nick's question, but hopefully that got at some of it. Y'all are getting a workout with the microphones.
Hi there. Thanks so much for this talk. I really appreciate the chance to talk about prevention research here. I had a question for you regarding screening and sort of the paradigm of how we, as physicians, sort of center ourselves in the process of delivering screening. And any thoughts you have around how we may perhaps empower patients to play a more active role in promoting screening, or maybe taking advantage of wait times or hospitalizations where there's a lot of downtime to sort of educate patients around the importance of screening so that they're prompting us to do it. Because it just seems like the overwhelm among primary care providers to hit all the different screening topics is just a everlasting battle.
Yeah, that's a great question. That was actually some of the basis with our My Preventive Care work. So the idea was that we were going to take all their electronic health record information, apply it to algorithms, and then show them personalized educational material around all of the preventive services. And I remember when we wrote our grant, we were talking with the National Cancer Institute, and they're like, you can't do all of preventive care. You have to do one thing, just do colon cancer. And it's like, well, that's not what we do in primary care. My job is to get all of the preventive care you need. I do think having ways to automate and identify needs and proactively reach out to people so that they're aware of their needs are key. I think patient education, I think shared decision-making, I think creating a culture of shared decision-making between clinicians and patients empowers them to be able to kind of manage and take care of their care as well. And I think also that we shouldn't be overly prescriptive about preventive care. So, many of us are like, oh, I got to close this care gap and make it go away. But, maybe that's not the right thing for the person at the right time. So I think us also having a patient-centered approach, where we're kind of thinking about what's right based on a person's needs, are very important. And we could do a better job of prioritizing things. So, okay, I mentioned that there was no one who was up to date on all 23 preventive services, but some are more important than others too. We know that as well. So having ways to prioritize, having ways to be proactive and automate educating and informing people of where they're at. I think all of those are key things. I suspect you all have care gaps and things like that that go into my chart, and spending time trying to make sure that those are right, and that they're the things that you want your system and your practices to drive delivery on. I think those are really important system issues to be working on. What I get frustrated with the care gaps in my chart is it's not linked to any educational material. You just see, oh, I'm overdue for hepatitis C screening. What does that mean? We need to get to that next level, and really our systems aren't doing that right now.
Thank you so much for this wonderful talk. I was curious to hear, have there been any big changes to task force recommendations that have come out of the research findings from PBRNs?
Well, there's been a lot of changes to task force recommendations, I'll say that. The PBRN evidence probably has informed the task force recommendations more on the implementation sections. I'm not sure PBRNs have had a big role in generating like the primary evidence on screening and those types of things. Although that being said, I do think that primary care and PBRNs, they have been involved in some of the things like the diabetes prevention program, which resulted in weight loss and diabetes screening recommendations. I think there were PBRNs and primary care certainly involved in the evidence around screening and counseling for unhealthy alcohol use and generating that. Yeah, depression and those things as well. The Cancer Screening Research Network that I mentioned, well, Acorn and Virginia is leaning into primary care for studying. The first test we're supposed to study are these new multi-cancer blood detection tests. And these tests kind of scare me as a doctor because I do the test and it comes back and says, you might have cancer. Some are tissue organ specific and some are not. But like it involves doing tests like making sure you're up on your regular preventive services, but maybe doing entire body CT scans to try and find your cancer. And then what does it mean if we don't find it, if you have pieces of DNA or cancer floating around in your blood? Like that's kind of scary. So I have been pushing for many years to have PBRNs more involved, and there are 8 different hubs across the nation for the cancer screening research networks, but Virginia's the one that's more primary care focused. A lot of the other networks are more cancer center focused. And I think the place to be doing these trials is in primary care. I will say that our Acorn network, we're involved in the STAR and SELECT trials. So the STAR trial led to our recommendations about BRCA testing and breast cancer chemoprevention. And the SELECT trial led to our recommendations against chemoprevention for prostate cancer. So there have been some involvement and there needs to be more.
This may be a bit of a cynical question, so I apologize in advance, but I think we can all agree, especially after reading the unhealthy alcohol use paper, that this is a very multifaceted problem. You have systemic racism in healthcare, you have mistrust of doctors from the patients, you have rural versus urban, all sorts of different issues that kind of affect the outcomes. So how do you reconcile and kind of what are your visions for the future of, do you think we can reach a place where we are able to use practice facilitation to actually further the treatment and further the intervention? Or are we going to be kind of perpetually stuck in limbo where there's always something that goes wrong?
Well, most every research paper ends with more research is needed. So that's kind of a standard line if you're trying to figure out how to end your paper. And there's always something more that you need to do with research. But like joking aside, I actually view our findings around the unhealthy alcohol use as really positive in the context that we were very inclusive about including a whole range of communities and practices serving different communities. And across all of them, we saw very profound changes. So yeah, we need to do more around improving the counseling and some of the treatments that were in there. Although most of the benefit with screening from unhealthy alcohol use comes from that brief counseling that primary care provides. I do think being very mindful up front about addressing issues like systemic racism and making sure that research is inclusive of people who aren't often included in research studies. So in our cancer screening research network, we made a big point of highlighting the original trials around cancer screening. A lot of what our recommendations were based on, there was this trial called the PLCO trial, prostate, lung, colon, ovarian cancer trial. And the prostate arm of this in the US, they enrolled 78,000 people, but there were only 4,000 Black men in the trial. So Black men are twice as likely to die from prostate cancer as other races. And 4,000 men didn't give us any ability to say, does this test work differently for Black men than for other men? So we're being extremely mindful, and I'd actually say that the whole NCI initiative is to make sure that we're being inclusive of all communities and representative of all communities. And it's so many factors. It is, like you said, systemic racism, the structural factors. There's rurality is a big issue. There's occupational exposures. And trying to collect the data up front to know what these things are and trying to make sure that you're designing the studies so that you're inclusive and can answer the questions for as many people as possible. I think that's a key thing. And I do think that's a place where practice-based research networks can help out, because that 1.1% academic center, that is a very exclusive population, however you define it. So getting out broader into the community is one strategy to try and address
Hi, thanks for your talk. It was very engaging. You mentioned that a lot of patients don't realize that their clinicians can help them with socioeconomic problems. I was wondering if you could go into some specifics about what healthcare practices can do for people who are socioeconomically disadvantaged.
I don't think we can do as much as we want to do. So let me start with that. I don't want to overblow what primary care can do or what health systems can do. And that's where I was saying some of what I think we need is more evidence about what is the role of healthcare in addressing social needs. And I'll just put a personal fear out there. You know, in the US, we spend 18% of our gross domestic product on healthcare. We spend 7% of our gross domestic product on social care. And that social care includes all of education, including higher education. So if you look at other countries, every other country's upside down from, we're upside down from every other country. They spend 18% on social care and 7% on healthcare. So I have some big fear that moving social care into healthcare is going to make it wildly expensive and less effective. So that's something we have to be really careful about avoiding. But you know, going back to the study we did with our doctors reflecting on their experiences with asking people about social care or social needs, I do think it's part of getting to know who you're taking care of, and knowing that someone is unhoused and living in their car, your treatment's going to be completely different than if they have stable housing. So there's some very simple things that we can do. There are more movements about trying to link healthcare with community programs. So Unitas is an example. That was an initiative in Virginia that put $10 million in to create connections between health system, electronic health records, and community programs that deliver social services. And it's a great idea, but where they really failed, they put no money into the social service programs. So they only put $10 million into making a referral to a social service program that's even more overwhelmed than the healthcare system's overwhelmed. So it has to be this more collaborative effort between kind of our social care and community care services and healthcare. Healthcare can do a really good job at identifying the needs, how it's impacting people, why they might need some support and services. And being able to think more about this interprofessional team that goes outside of our traditional healthcare walls. I think that's where we need to be moving. But there are simple things you can do. There's resources you can send people to. Many of us have social workers and psychologists that we can link people to. And like when we started that enhanced care planning project, we did asset mapping. We found 250 programs throughout the greater Richmond area that did everything from food to housing to jobs to mental health. And so knowing your community and your resources can be a good start as well. That's a lot to ask of clinicians. So thinking of the systems to make it easier is important.
So thank you for such a fantastic and engaging seminar. We could give everyone a round of applause.